a patient with a more than 20-year history of oral cancer, surgical procedures, chemoradiation, and immunotherapy presents with a new lesion in the hypopharynx. The patient has a long history of difficult intubation, including awake intubations, but for this very short procedure, the surgeon requested that we consider high-flow nasal oxygen and no tracheal intubation. After careful assessment, including preoperative endoscopic airway evaluation, which revealed rigid tissues and severe hypopharyngeal stenosis, the patient was brought to the operating room. High-flow nasal oxygen, or Thrive, at 40 liters per minute was instituted, and the patient underwent a carefully planned IV induction of anesthesia with the slow introduction of positive pressure ventilation. Once positive pressure ventilation was assured, intermediate-acting muscle relaxants was given. High-flow nasal oxygen was increased to 70 liters per minute. A flexible intubation scope was placed into the airway, as well as a ball cup forceps to achieve the biopsy. Adequate exposure was not possible, and the flexible endoscope was removed in favor of a suspension laryngoscope, which gave no view of the larynx and lesion. The flexible endoscope was reintroduced with manual extraction of the tongue. Suction is applied to clear secretions and blood. The ball forceps is reintroduced and a successful biopsy is taken. After hemostasis was achieved, the patient was emerged from general anesthesia and resumed spontaneous ventilation. During the 25-minute surgical procedure, the oxygen saturation did not vary from 100%. End-tidal CO2 was briefly measured at the end of the procedure with manual ventilation and was found to be in the 75 millimeter of mercury range. After 1 hour in the post-anesthesia recovery unit, the patient was discharged to home.